125 people in a command center, so there are teams of people for each of the Epic applications, literally sitting and waiting to correct anything that goes wrong. And we have a number of dispatch areas where we cluster people ready to head out if something comes up that they're needed for in the hospital. So logistically, it's a huge project, and it's one that we hope will go smoothly, but things do come up. And Epic actually talks, the famous Gartner curve, where you start out and everyone's very excited, and you go for a week or two, and this is great, this is really cool, and then you start to notice all the problems, and you fall into the valley of despair. And that usually happens about a month or two into the project. And then by 3 or 4 months, you're coming out of the valley of despair, and people are starting to say, wow, this is okay, I can live with this. And then by 7 or 8 months, it's, wow, I don't know how I ever didn't live with this. That's when you start to get the real benefits of an electronic health record. But the change is a wrenching one. It's wrenching for the physicians, it's wrenching for the nurses, and it's wrenching for the support staff and the financial people, the operations people. Everyone has to do things differently than they did before. So it's a big change for any hospital to go on to an EHR. I think that we're finally approaching the point where maybe it's not 5 years away, but I still don't think it'll be used by everybody. And you have to be clear, we're talking about really two types of voice recognition. We have voice recognition on the back end that's used really in place of normal dictation or transcription. And the advantage there is that the technology is such that you can improve its accuracy by doing statistically multiple runs on it. This is eScription's old technology, and it works very well. But to a doctor, to the doctor that's using it, it's completely transparent. It's just like they've always done. You're talking to the microphone, you get a printed document back, that printed document goes in the record. Only these days it's scanned and it becomes part of the record. What's different is front-end voice recognition, where the physician is dictating directly into a document and maybe even navigating through that electronic health record using commands that are part of the voice recognition, and there it's a decidedly mixed bag. There are many physicians, and we have a lot of physicians now who are just rabid supporters of Nuance and its speech recognition products on the front end. And we have one doctor, Dr. Dan Friedland, who's spoken many times about not only using it in his practice, but also the way he's created macros so that it creates entire documents, and so that he navigates through his user interface using it. He does everything. He never touches the keyboard. But I'd put him at the extreme. Most docs will use voice recognition in the context of certain blocks of text that lend themselves to less structured entry. So, for instance, a history of the present illness, or the family history. And what they'll do is they'll dictate that portion of the record using the speech recognition. And it's working better and better, and they're getting better and better at it. Of course, the advent of enterprise versions of Nuance or of Dragon has been very helpful, because now we don't have to worry about putting profiles on each computer. Now that can be handled by a server and very quickly brought down to the computer they're using. We have less problems these days with microphones, so a lot of the technical obstacles are going away. Now it's just become a question of some docs like dictating using voice recognition, and some just don't seem to get the hand of it. Or worse, they just come into it expecting it to be perfect, and when they have to correct anything, they say, well, I might as well just dictated this and had it transcribed. I'm not a typist. They don't want to go in and fix the 5 words that have to be fixed. in their 5 paragraphs of text. I'm relieved because, number one, I think that the federal government will be more likely to continue to honor and to complete all the work they've done around encouraging the adoption of electronic health records and meaningful use of electronic health records. I think that there was some concern that with the change of administration that there might be some retrenchment around those programs. You know, there was some $40 billion, of which only about $9 billion has actually been paid out. And we, like most hospitals, are very anxious to get our meaningful use dollars. We're working hard to make sure that we maximize what we qualify for. So that's one thing that I think makes me glad that that we're not having a change of administration, that we'll most likely stick to the policies we have. The second is, and now people are very, people differ on this, but I will admit to being a supporter of the Accountable Care Act to the extent that it provides coverage for more people. Now, I don't know that it saves on costs, and we still have that as a major obstacle that we're going to have to address in healthcare. But I do think that we will provide for more care, and I also think that under these new schemas where we're start talking about things like accountable care organizations and patient-centered medical homes, all of these things that are aimed towards not only controlling costs, but controlling the quality and the patient satisfaction with the care they're getting, but cost too. I think that in those programs that they demand that not only that we have electronic health records, but that we be able to pull the data out of those records to use it to measure ourselves. And we will need to become increasingly more sophisticated in our ability to gauge honestly the quality and cost of the care that we're delivering. And so I think that with this administration, we will continue to move towards things like accountable care organizations, and I think at the same time, I know we're investing outside of electronic health record, we're investing heavily in analytics and business intelligence capabilities to be able to tell for populations what kind of care we're delivering and how well we're doing, because that's going to help us meet the targets that we're expected to meet in that future accountable care world. It's probably between $8 and $9 million that we've received thus far. We expect eventually, across all of MaineHealth, we expect eventually to receive close to $60 million in accountable, meaningful use funds, and I'll be honest with you, the cost of our Epic implementation is probably about $160 million, and so that $60 million in meaningful use funds, while it doesn't cover the cost of that, it certainly helps cover that capital investment. So we are very much geared towards collecting as much of the meaningful use opportunity as we can. We also think that it's good care to do it, because most of those meaningful use criteria are aimed towards quality and ultimately towards better outcomes. So you're doing the right thing anyway, and so we've collected our ambulatory practices have attested for this past year already. One of our hospitals attested this year. We've attested under Medicaid this year for all of our facilities, and this next year Maine Medical Center and some of the other hospitals will attest for the hospital portion of their meaningful use funds.